don't assume that everything is okay. And same thing, I told about the pregnant lady and delivered, and at the 4th or 5th day, patient, they identified the patient as paraplegia. Everything is okay. They had a test, they had an A, they had a B, they had a C, everything is done, they have preserved the life, that's good, but missed the part disability, D. They didn't look at that one. Maybe at that time patient was not pain and the Russian thing, but no. Primary survey, we should go systematically, always do the same again and again, the same to each and every patient. A simple missing that the totally change the patient's life, die or disability. And then the disability, we see, simple. Airway, assess the responsiveness, can talk or muffled or silence. 3 scenarios. Can talk, that's perfect, but still we should assume whether will it be patent in about 15 or 20 minutes or half an hour later. If you are thinking in that case, say for example, swelling here, injury here, or the burn injury, electively intubate. No harm, we can extubate later. Okay, but thinking that is pain injury, so we have to intubate accordingly. So anything they know what to do with that one, that's fine. Right. And then look the chest and actually not chest, head and neck, external injuries or any swelling or crepitus, right? And feel they are whether it's moving in and out from the nose. Okay, if you think those things, then the suction and take the foreign body out, and if the tongue is falling down, then we can correct that. Okay. When to intubate the patient? If the disease is less than 9 or 8, we have to go for a definitive ARA. We no point of putting what you call LMA or whatever the instruments or the ARA or anything, no point. Okay, we have to intubate the patient. Right? If you can't intubate the patient for some reason, what to do? We have to go for a surgical definitive ARA, tracheostomy. Okay. Breathing again, breathing and ventilation. Okay, inspect the chest movement ups and down. Is there any wounds? Palpate the chest for crepitus, whether it's moving or not. If you palpate the chest, you can identify reflection. You can feel the subcutaneous emphysema. It means if you can feel a subcutaneous emphysema, it means obviously it's a reflection. Okay, reflection or whatever the lung injuries or trachea injuries, it means something air is leaking outside from the lungs. Right? Percussion, yes, you can do, okay, and manage the life-threatening conditions here. Tension pneumothorax or open pneumothorax, flare chest or massive hemothorax. If you think chest is not expanding or over-expanded, okay, no AIND on that side. I'm not going to talk about how to differentiate between the tension pneumothorax from hemothorax and which side. I'm not going to talk about here, okay. In few things like that, respond immediately, don't wait for X-ray. IC tube on the diagnosed side. Okay, don't worry. Immediately put an IC tube in the A&E, and ideally the A&E team should put an IC tube, not the surgical team. Okay, ideal setup is that for the country, but here we both, if you can do put an IC tube, that's fine, or A&E team, surgical teams around. Don't wait to put the IC tube until the patient comes to the theatre. No need to bring the patient to the theatre and put the ICT. But now setup, what to do, can't help. We don't have that facility and monitoring and instruments. Or in a safer place, sometimes we think that putting ICT in the theatre is more safer than putting the ICT in the A&E. Right? But we have to do it then and there. Then only we can ensure the patient's life. Oxygen, chest drain. Don't wait for imaging. That is a take-home imaging. Don't wait for the imaging. Even though if it is negative chest, if you are suspecting, just go ahead. Okay? Missing the pathology is really deadly. Okay? Just doing the negative procedure. If it is negative, that's fine. Okay? If you are thinking on that onset, do. And later on, if it is negative, that chemotherapy is fine. What to do? After minutes or hours, we can, after doing the imaging again, if everything is okay, then we can remove that one. Okay? Considering the patient's life. Circulation again, control external bleeding, IV access, diet glucanidine means age 14 or 16, at least 18, ideally 16. But what we do, we put pink cannula or blue sometimes. Okay, just put a cannula, that's fine. Large cannula, if you can't get access, get down an anesthetist who is very competent on putting what you call cannulation. They can put a CV line or the neck line or femoral line or femoral cannulation. At that moment, we had to just to make patent circulation. We had to give some fluids or blood and drugs. Okay. Same time, when you are cannulating the patient, get the blood sample for cosmetic. And do the lactate and do the CBS. Why CBS here? Lactate is okay, fine, you know, polytrauma, blah, blah, that acidosis and breathing is compromised, so acidosis. Do you want to do like CBS for all patients with polytrauma? Do you think that polytrauma can cause glucose or hypoglycemia? It's other way around. Hypoglycemic patient has had a metal crash or fallen from height or while driving patient might have had some hypoglycemia for any reason and have collided with something. Okay, now when they bring the patient to the hospital and whatever we do, if you miss a hypoglycemia, by then always do the CBS whether it's okay or not. Okay, it's other way around, right? Right. And start fluids, better avoid normal saline, no expanders. No fluid expanders. We in our medical students time next and plasma, but some plasma I have forgotten the names. Okay, so no more talk about these fluid expanders these days. Crystalline or blood. Even normal, better avoid normal saline. Okay, if you give massive normal saline, it will get acidosis. That is not a physiological fluid at all. Okay, no normal saline. Brincolatics. Okay, crystallites or blood. Here we are getting blood loss, basically blood loss. That's the reason, ABC, blood loss. That's the reason for the low GCS. Do you get a patient with 5 days of diarrhea and 10 days of vomiting and dehydration? Yes, but that is not a polytrauma. That's a different category to deal with. Okay, so patient comes with a polytrauma, low BP, blood loss. We have to give blood and blood products. Acute blood loss. No point of giving blood alone. Acute blood loss. So patient is losing. This is not a patient who came to the hospital with a what you call anemia of chronic disease. Okay, blood loss means that blood losing the clotting factors and everything at the same time. Platelets, clotting factors, everything is losing. Everything is going down. So we have to replace. So 1:1:1. Give blood. Okay, blood. FFP and platelet 1:1:1 starting. Then whether to start the massive transfusion, that's a different discussion. That will be decided later by the A&E team or the surgery team. Okay, at the same time, telling by the don't forget that and telling again and again and avoid excessive crystalline. Okay, blood is not the BP and pulse rate is they are not improving. So do you give again and again crystalline? No point. Okay. Don't overload with the crystallites. Then anyway patient will get the DAC and patient will die. No point of talking about that. So immediately give one to see the challenge. Not go for blood. What is permissive hypotension? In polytrauma patient, we do not resuscitate the patient to get the BP back to normal 120, 130 because bleeding inside somewhere. Okay. If you make the BP normal, no bleeding. That's what permissive hypotension. We just permit that hypotension to around 90. Accordingly, we resuscitate. Right? D for disability, GCS. Okay, ODC, ABPU, the quick assessment. Whether patients responding to alert, only responding to the verbal or pain, one response, ABPU. Rather than for a GCS from, even if I ask GCS now, what is stand for the eye response or the limb response? No one will tell exactly correct GCS. I'm dead sure here, even myself, including myself. Confusing. GCS is a very confusing thing if you unless you do day by day, daily, each and every patient. Okay, right. Good thing is ABPU, alert, verbal, pain, and unresponse. Right. ABPU, assess the patient immediately and act accordingly. And people say blood glucose, again see blood glucose. Right. Exposure. fully expose the patient, load the patient and see the back and all the body parts, and again load back to the position. Okay, don't miss this one because spinal injuries are missed because of this. You just see the ABC and just everything is fine and act accordingly and miss the spinal cord injury. Patient end up with a paraplegic or sometimes quadriplegic, right? And neurogenic shock. Miss the neurogenic shock, think that patient is bleeding inside, bleeding the blood and blood product, patient will die. Okay? And home fluids. Explosion, remove the dresses and then dress it back. The hypothermia part is polytrauma patients tends to develop hypothermia quickly, but in our country, no, that's slightly better. We are better. In the UK, Australia, you know, the freezing cold and snow outside. If you just undress the patient, immediately patient will go into hypothermia. Means hypothermia to our setup, somewhat we are safer. So in the polytrauma, we talk about the lethal triad. What is a lethal triad? Hypothermia, acidosis, and coagulopathy. The purpose of management in polytrauma to avoid this lethal triad. Hypothermia can cause acidosis and coagulopathy. Coagulopathy can cause acidosis. Acidosis can cause coagulopathy. Is a triad. Disaster. Okay? Fine. So secondary survey, everything is fine. Primary survey is done. And life is safe now. Initial resuscitation is done. Patient is stable. Now we can move the patient to any ICU or theatre or imaging or whatever it is. Then we can do the secondary survey, head-to-toe examination to assess some associated injuries. Right? What are the investigation we do in trauma patients? You know, we do the fast scan and e-fast. Fast scan we do to see fluids. With the fast scan, we can tell you there's a liver injury, spleen injury, grading the spleen, splenic injury, grading the liver injuries. No. It's a scan, fluid or not, how the minimal, not right, something like that. Right. What are the X-rays to be taken in a patient comes a trauma? Forget the trauma. Only 3 X-rays, remember. C-spine, chest X-ray, pelvic X-ray. We can't miss the C-spine. Okay? So C-spine, what's C-spine? AP or lateral or only we can take AP. Why we can't do the lateral X-ray? Already we are assuming this is spine injury. Can you do the lateral X-ray here? No. Understand? AP and chest X-ray always and pelvic. This is a trauma series imaging. First X-ray. Right? And in our foreign countries, A&E has a CT next door. Just next door or the next entrance CT. Immediately do the CT and head-to-toe CT and manage everything. Here, not like that. Okay, CT, if the patient is 100% stable, everything is fine, life is safe, then we go for classes. So we research and data. And then ABG and lactate, same blood sample, we can do everything together. Okay, cross match and everything. Right. The unstable patient goes to the operating room, not to the CT. Fine. Use the imaging to guide, not to delay. But we do, okay, do the CT, do the X-ray, and assess the patient again and again, and then talk to the relatives and talk over the phone to the consultant, all the specialty, put the referrals, that's important part. Whatever the patients come, we put the referrals. Patient comes with the polytrauma, but the diabetic, so put the weak referral. And polytrauma patient is dying, and the patient can pass it, so 10 years back, patient can MI, so weak referral. Okay, that's what we do. Okay, so act accordingly, okay?